who could be better than the wonderful and awesome David Wilson? And so we're very, very lucky at the Health Economics Unit that we get to work with a whole different group of people all over the country. So we're very lucky to be doing pop health management from it's down in Cornwall all the way up into the northeast. We get to work with our friends in Northern Ireland. We're also helping and working with our friends in Jersey on other bits, but we also get to talk and work with our friends at the World Bank. And we've worked with them on a number of projects with looking at PBR and pain by results in Slovakia, and but also work in Poland. And but I've been very lucky to talk for the World Bank on prevention and sharing some of the excellent work that you guys are doing, because of course I don't do it, I do it with you. And so it's many of you on this call who've been doing some excellent pop health management stuff, mainly talking about prevention and how we deal with those wider determinants of health. And on those talks, I managed to sit on the agenda right next to David. And David's talk really, really resonated with me. And I thought it was, which is why I begged and I promised to buy him copies forever in the opportunity to have him to talk to us, because David's role at the World Bank, where we have a role or a vision across the whole of England, David gets to see the whole globe in his role and to be able to experience many of the same challenges that we're facing, but also see many of the same, or sorry, different solutions and creative ways that people are using innovative technologies to be able to address and manage prevention. So we thought, what a great opportunity to be able to see David and have a proper conversation with him about prevention and his role across there. So I hope, well, a fraction of the build-up you needed, David, for one, but over to you and for you to share your experiences with, say, prevention in healthcare.
Thank you very much indeed, and it's a pleasure to be with you today. We follow what happens in the UK and the NHS with immense interest, and Andy's been very kind about the World Bank. I think I should say we're primarily a financing rather than a technical agency, so you have a lot more technical depth than us. And we also tend to have a 30,000 feet view, which has some comparative strengths, but a lot of weaknesses. So those are really the disclaimers I would begin with. And I'd also say that this is based on a session that Andy and I did in Poland recently, and our brief was to enthuse the Poles about digital innovation. So my piece was unashamedly advocacy oriented, and I'm going to present it to, I think, a much more skeptical British audience, and that's why I've entitled it Hope or Hype. To what extent can we really rely on tech innovation to strengthen preventive health, population health, promotive health? How much is well-founded hope and how much is hype? So let's see how this advocacy presentation plays out with a more critical eye. And I'm going to begin by unashamedly borrowing data from the UK itself. I don't think there's a better graph than this, which just illustrates how big the disparities in life expectancy, and especially healthy life expectancies, are based on socioeconomic factors. It's the clearest, starkest graph, and we always use it. Another nice little piece that we all know, determinants of health, which really shows how the field has moved, because these data are all available for people to play with on GitHub, and this marvelous poster is for sale on Amazon. So it's a new world and they've embraced it beautifully, but it really makes the point, relying on US data, that about 11% of the determinants of health are situated in the healthcare sphere, and the rest is the subject of today's discussion. And we all know the three major determinants of health: the socioeconomic, the behavioral, and the biomedical. And I think the reason this is so timely is I think we would all agree that if we look at the big improvements in population health over the last century or so, nearly all of them are actually due to two biomedical interventions: vaccines and antibiotics, and to three socioeconomic interventions: nutrition, housing, and water and sanitation. So almost everything we've achieved in health is actually through the biomedical or the socioeconomic. And that doesn't leave a lot of space for the population health field that we work in, and especially for behavioral interventions. And we all agree that behavior is absolutely fundamental to health. It has a huge role, but behavior change is hard, and most systematic reviews point to inconsistent findings and weak, small size effects. And the problem is that the most effective behavioral interventions tend to require intense, prolonged individual support, which is costly and hard to scale. And we all know, you know it in the UK, you've illustrated it more powerfully in the UK than elsewhere, that inequality is probably the greatest socioeconomic challenge, and it's getting worse globally. And we know the worst health outcomes are concentrated in lower income and also lower status communities. And again, you've articulated this beautifully in the UK. But I think the reason this is so timely is I think most of us would agree that COVID compressed decades of progress in the life sciences into months and years. And it's given the life sciences an absolute turbo boost. And we've got new therapies, vaccines, and devices which are going to radically reduce NC disease and burden. And you know them all. And their role in preventing sickness is going to be an absolute blessing. But they won't create well-being on their own. We're not going to be able to take pills, injections, and devices that give us well-being. But they do give us a stronger foundation to work towards well-being. And I think the really important thing is they make the behavior changes that are needed for well-being so much smaller. And a golden rule of behavior change, it's much easier to make small behavior changes than big ones. And the timely example I always give during COVID, it's much easier to get a vaccination than to shelter in place for months on end. Small behavior changes are achievable, big ones are much harder. And here's just a reminder from the Cochrane Public Health Reviews of how few behavioral interventions have shown consistent, strong effects. And fewer than 10% have had favorable results in the Cochrane systematic reviews, which is where I tend to start when I'm looking at evidence for something specific. And we all know why behavioral interventions are so hard. We've discussed that it plays a huge role in health, but changing behavior is hard. And the point I want to make, it's relatively easy to lose a health promotive culture based on healthy food, based on physical activity, based on family and social community bonds. And it's very hard to restore it once we've lost it. So healthy cultures are easy to lose, hard to rebuild. I know almost no examples where we've rebuilt a healthy community after we've lost it. And we all know this. Most behaviors are actually socially determined, and yet most of our behavioral interventions are individually focused. And we also know that we face multiple overlapping, reinforcing comorbidities and diseases. And the UK has illustrated this beautifully. We don't just have one problem, we have a constellation of problems, making the behavior change even harder to disentangle. And we also know that lower income groups, minorities, and migrants face additional challenges. And we also know that our health systems struggle to develop preventive care. And we look so closely at what the NHS does here. And I think many of these things are true, even in the UK. Healthcare time is costly and extremely limited. Health workers lack the training in preventive health. They lack visibility into critical care gaps. Care coordination is critical, but it's complex and infrequent. And there's very little personalization. And the patient experience is usually confusing and inconvenient. So our sense is that in the UK, if you're very sick, the NHS is a wonderful place to be. But is it equipped for the population health and the promotive health challenges? And if it isn't, who is? Are there good examples? And so the question I want to pose today is, given how hard this is, given how healthcare workers' time is so scarce, given how intensive behavioral change interventions need to be, given the budget constraints we're under, can digital innovations save and revitalize health promotion? And I would say perhaps, but I think to succeed, we need more comprehensive approaches. And I think we're starting to see some in the usual small state examples such as Singapore and South Korea, where you've got three key bedrocks. You've got a comprehensive, all-of-government digital health promotion strategy, which most countries don't have. You've got a real-time evaluation plan to assess how it's progressing and what its impact is. And you've got rapid learning and adaptation. And we've seen a few examples of countries trying to do this, the usual small state examples I've cited, but not many. And you'll be a judge yourself of where the UK, England in particular stands, England, Northern Ireland in particular for this audience stand in this regard. And why do we think that digital innovations may offer a potential pathway to effective health promotion? Well, we're hoping they move us from a place that's characterized by very broad mass media messages directed to seniors, women, minorities, to reactive messages, to very weak intermittent monitoring through annual checkups or when we just happen to be sick, and through very infrequent episodic health worker engagement to something that's very different, to something that's personalized and informed by genetic, biological, medical, psychological issues. Just as we're seeing personalized biomedicine, we have an opportunity to start to work towards personalized health promotion. Predictive analytics, and Andy and the HEU team do some of the best work in the world here. I don't need to elaborate on this, but also on permanent monitoring through connected devices, through implants, through sensors, and linked to AI-managed monitoring systems, and very powerful patient engagement through a whole host of digital monitoring, feedback, messaging, reinforcement, triaging approaches. So the potential's there if we can realize it. And the three steps that I've borrowed here from Singapore are: first, measure, evaluate, and adapt, build a strong base of health and wider data, put it together. And that's where we so often fail, is to put the data together from all the different sectors and use that to build personalized predictive plans. So I'm going to suggest that the 4 Ps that digital health might help us to realize are the personalized, the predictive, the permanent monitoring, and the powerful patient engagement, if we can get it all right. And you know as much about personalized health promotion as anyone in the world. Care teams assess individual needs, they develop individual plans, they set joint goals with patients, they develop individualized metrics for success, and then the care teams use both physical, but more importantly, also digital resources to monitor and reinforce. So that's the vision of a more personalized health promotion. And here's a nice little graphic. I don't need to go into detail. It really illustrates the steps that we've just spoken about. And it's important to emphasize, and this graphic lays it out quite nicely, that a personal health promotion planning is not just, as I've said earlier, about the avoidance of sickness, but it's about mindfulness, it's about self-care, it's about more than just preventing sickness. And we have the potential to do more of this in a digital world. And there's so many good examples. I've just chosen one here, smoking, where the US has a program that's based on a digital app and a handheld carbon monoxide breath scanner that delivers an intervention reinforced by the biomedical breath scanning and seems to be much more effective in helping people to reduce smoking. And the reason I've cited this is it brings together what I think is increasingly going to be the future of digital health, and that is constant access to biomedical monitoring and constant access to behavioral monitoring, but brought together. And that's the power. And now we're at a subject I'll gloss over because you know it so well, but predictive analytics, using AI to predict future health events. And there's so much we can now use. I'm going to move quickly through the section because so many people here know it well. These are the sorts of questions we want to answer. Proactively preventing disease. What other diseases is the person susceptible to? Who's going to get more serious infections or illnesses? Can we intervene sooner for some patients? Can we identify likelihood of readmission and manage it? What's the likelihood of people simply not showing up and falling through the system? How long will they need care? How many and what kinds of health workers are we going to need in future? And how much money will a patient cost the health system? So those are some of the questions that predictive analytics can help with. And I want to choose a nice example from our backyard, the World Bank's in Washington, which is in a tri-state area comprising Washington itself, Maryland, and Virginia. And this is the example from Maryland, a quite deprived state just to the north of Washington. And they used predictive analytics to identify and to reduce readmission by super users. And what they found is 5% of patients accounted for half of all health costs and 70% of readmissions in the US. And I'm sure those data are familiar to colleagues here as well. And they used AI to try and identify the 5% of patients that accounted for 70% of readmissions and worked with their 24 local health departments in a state of about 6 million people to track and manage these patients without readmission. And they found they very quickly reduced readmissions by a fifth and costs commensurately. And we have another even more powerful example, which I'll only touch on briefly today, from New Zealand, where they looked beyond health and they found that there were a small subset of babies who were going to cost the state $1 million by the time they were 30. And these would be in health costs, but also in juvenile delinquency and remand costs, in adult prison costs, in adult psychiatric care costs. And they said, how do we find these $1 million babies and how do we work to prevent it? And this involved an all-of-government approach that was extremely successful and cost-effective in really trying to avert the predictable and obvious cases of the $1 million babies who are going to cost the legal, the health, the judicial system that $1 million or more. Then we move to permanent monitoring. And we all know about the Internet of Things, wearables, implants, ingests, sensors, which are really transforming healthcare from episodic visits and lab tests to permanent monitoring, linked through AI to remotely managed data flows. So the vision here is we all have connected devices, monitored for the most part by AI, and then triaged to healthcare workers as necessary. And this isn't as far-fetched as it sounds. We've got so many examples now of remote monitoring and health promotion. You know them all better than me, so I won't go through the list individually, but here are just some examples of how we can do remote monitoring today. And there's so many good examples of remote monitoring, and one of the examples we always give is in Israel, all new mothers get a kit that they can attach to their phones, their smartphones, and which provide perfect ear, nose, and throat sensors. And they've actually found the images through smartphones are often better than the images that pediatricians can get in offices. So effectively, every mum gets a kit to allow her child to be remotely monitored and managed with the same clinical accuracy as you could do in person. And this is now expanding from pediatrics to other areas of care. And I'm sure it's going to be a big part of the future of healthcare. We've touched on how weak patient engagement is in health promotion. And I think it's fair to say in most countries, perhaps also in England and the UK as a whole, that we really only engage intensively with a patient when they're very sick, when they're catastrophically ill. That's the moment at which intense engagement happens. Before catastrophic illness, engagement is extremely intermittent. And we hope that digital care tools can change that. Firstly, by enabling patients to integrate the virtual and physical worlds and to have 24/7 engagement that's largely under their control. And simple things like scheduling, prescriptions, telemedicine, access to motivational resources, increasingly directed by AI, remote patient monitoring, which we've spoken about, personalized prescriptions, which we've also spoken about, and the opportunity to change health promotion and healthcare from physician-led to patient-led. And I think those are the opportunities that we have if we can use digital as a platform for powerful patient engagement. And there's so many good examples. We all know the examples of exercise adherence in South Africa. Discovery Health in the Western Cape pioneered a system where they offered health insurance and life insurance discounts to people who wore linked fitness bands. And these discounts increased as they met their exercise and heart rate targets. And they actually had strong internal proprietary evidence that it was cost saving for them. So they were all in on this because they could see the benefits. And we know the many diabetes adherence devices we now have. I've just cited one from the US, but there are many, many of them. Then, can digital innovations actually save, preventive and promotive healthcare? I'm asking the same question again, and I'm saying perhaps again, but I'm reiterating. It's not going to happen by itself. It's not going to happen piecemeal. If we want it to happen, we need that comprehensive all of government digital health promotion strategy. We need a real-time evaluation plan, and we need rapid learning and adaptation. And so far, we only see that in a handful of places. So let me move briefly to the conclusion so we can have as much time for discussion as possible. I think we would agree that the future of healthcare is going to be about predicting before time, detecting before time, modifying before time, and treating before time. And I'm very fond of a saying of the US economist Tyler Cohen, where he talks of marginal revolutions, and he argues that dramatic change is actually the result of accretions of small change. So accumulations of incremental improvements can be transformative. They can tip things over. And that's where I think we can go in healthcare if we get it right. And we've also got the potential that where we fail, the near future also includes amazing technologies for regeneration in the life sciences. So from both a health promotion point of view and from a recovering from catastrophe point of view, the future is remarkable. And let me touch on where I think we all agree we're probably going. We're going from healthcare being physically located to being everywhere. As high technology, homes constantly connected, implants send constant data to AI for constant monitoring, triaging, and action. And we're going to be post-telemedicine because telemedicine will be so ubiquitous we'll scarcely notice it. We all agree we're likely to move towards smaller hospitals with much, much wider reach and remits, and to much more personalized medicine in the biosphere through genomics, metabiomes, microbiomes, but also in health promotion. And above all, as I said earlier, geared towards the future, towards diagnosing, modifying, and treating before time. Thanks very much. Let me pause there after a rapid scan of the slides, and then we can open for discussion. Thank you.
Thank you ever so much, David. And I say, going through these slides, it something reminds me of so many exciting bits to talk about. And thank you ever so much. And again, for everybody on the call, one of the great reasons we've got David is that you get a chance to quiz him now and to be able to ask some of the questions he's going through. And but I will take, not that I'm the chair, but I will take the privilege of gossiping first because I have the opportunity. David, one of the big things I know that we've talked about and you've mentioned is this idea that when we look at social determinants of health, it is this social problem. It's this idea that it's a problem not so even though individuals face it, it's a societal issue, yet many of the solutions we come up with are personal. And I know you talk about this idea of government versus system versus local. What do you think? What are the kind of key bits that we can do? Or have you seen where there's been success, where people have gone so that whole groups or parts of society are faced or addressed and offered interventions rather than just very special individuals, the super users, let's just do them, but we're not, often in healthcare, not the societal reasons behind it. Where have you seen success in society-based approaches?
I just begin by saying that I think we'd all agree it's so much wider than health. We're not going to intervene to address community level determinants of poor health if we can only do it at the healthcare level. It really has to be at the social and economic level. Through things like much better early childhood interventions, better schooling, better skilling, better job opportunities, better mobility. So I see it very much as a focus on using as many different social and economic interventions as possible to give everybody an opportunity to succeed. So I think it's really about working with disadvantage and deprivation at the community level, and health is would be a positive consequence of succeeding in those social economic interventions. I see it as a much wider challenge.
Yeah, and I think that we have, in some cases, this idea of our integrated care systems in England, in theory, offer us the opportunity to do that. But often this is healthcare led, and then what we come up with are healthcare solutions because it's what the NHS knows. We're really, really good at treating you when you're ill, and we're really good at getting funding for that and funding for more hospitals, but not for let's say the prevention piece. And I was wondering if there was somewhere around the world which has been an exemplar, somewhere hot that I could take people if we had the budget to do it.
I mean, I think you have the usual small state examples. I think Singapore has succeeded remarkably in identifying entire communities of deprivation and ensuring they get the skills and it's reflected now in their life expectancy, which is closing in to be amongst the highest in the world. So I think they're examples. The issue is how transferable the examples are for one reason or the other. But I do think in the UK, my observation is we also face the challenge of quite entrenched inequality and intergenerational inequality, which is even harder to deal with, I think. So, I mean, a concentration on uplifting those communities is beyond health is just so important.
Yeah, we're with you on that. There is some where I live in Hackney. There's a wonderful housing project, one of the first ever Victorian housing projects that they put in place to help the poorest people. And in that gorgeous red brick building where they built a school, they built a very small hospital to look after them, and they have these flats, and in those flats are people where they've lived for generations in social housing, but those houses now are in part of the trendiest part of London, and you have people living in those flats who earn well over six figures, who have jobs as fund managers, who park the Porsches outside, and they have this jarring levels of deprivation, living cheap by jowl, and of course the tensions that travel with it. It's how we kind of manage those.
Of course.
I've just been nudged to say, can we stop sharing the slides? Because I'm guessing they don't want to see my face, David. I'm guessing it's just so we can see you. And to remind,
if someone wants to help me switch them off, please do.
I'll look to Phil with his magic of being able to take over and do all this stuff. But and just in this small pause, for anybody in the audience who wants to ask David a question about what we've seen here, and of course to share your experiences, because one of the great things is working with our friends at the World Bank is that we're able to share what we're doing in England with those guys. So again, if you've got some great examples of where you've used technology, which maybe let's go forwards from there. James, and just to say, obviously, when we're talking about deprivation, let's go to Surrey.
Yeah, maybe a less stark example, but still, actually, in some ways, in Surrey, I think that as the saying goes, the inequalities within regions are always greater than the inequalities between them, and arguably we've got deprivation just like anywhere else. It's just maybe slightly more difficult to find among the averages in Surrey than elsewhere. But I had a question actually, David. Thank you for the presentation. It's really interesting and thought-provoking. But I wondered where you might have seen the sort of ethical discussions about what is or isn't the limit of what we can do done well at a national level, because obviously prediction and profiling are close together, not just in the dictionary. And the idea that you might give somebody who's got a weight problem a monitor that will tell them whenever they're not doing enough exercise might not be something that everybody would see as a sort of welcome development. So I guess, how do you where are there places that are having that discussion in a productive way, a national level, because that's often beyond the resources of the comms and engagement teams in small individual parts of the system?
I suspect the UK is doing that as thoughtfully as anybody. Honestly, I think that they've been very alive to some of the ethical challenges in the whole sphere of AI. So I don't think they're great examples elsewhere. I think in response to your point about giving people with weight issues exercise monitoring equipment, in most of the West, we probably all need to exercise more. So you can do it in a much more broadly based way. I saw a statistic today, which I haven't managed to check, but that Australia now is the 5th most inactive country in the world in terms of levels of physical activity. And they're now developing a plan to change that. And that plan would mean targeting a lot of people. So I do think there are ways we can target more inclusively, if I could put it that way. And that only deals with your example, but I think there are others. Yeah.
I guess though, how do you on that model? If I'm just one sort of follow up, I guess if you have a broad sort of target like that, say, let's try and increase everybody's rate of exercise, then you end up maybe helping those people who need less help more than those people who, so it's a really hard issue to think about, isn't it?
You can probably still balance both. You can offer the machines and the opportunities broadly, but focus the coaching and the support a little more precisely, in a way that I think deals with some of the legitimate stigma challenges that you've raised. And I think that's one of the beauties of a world of connected devices and AI triaging is we can go both big and personalized. And I think that just needs to be underscored again and again. We can be scaled and personalized, and that hasn't been possible before digitalization.
We've had a whole host of issues around the use of data for what we call pop health management, this idea of having a look at some of the prevention bits beyond, where we have been using a shortcut with section 251, which is a way that we could get around this, which again is kind of coming to an end now, and it's again how we can use data appropriately to be able to better understand our population to make decisions, but also to understand our population to make individual decisions for that person. And it's separating those bits out, and IG will always say that they were there. But 7 years now I've worked at NHS England talking about pop health management. Never once have I found two IG cats who agree on the same thing. If you put them in a room together, they always end up. At one point I was told that integrating data for this meant I should be jailed. But anyway, it is always a challenge. James, do you have any follow-ups before I move to Joanne? Excellent, so fantastic. Joanne, over to you.
Thank you. My question builds on the previous conversations that we've just been having. So many of the interventions assume that people want to be helped. How do you encourage people to own their own health and take up the offering of the interventions that are being proposed?
I mean, I can only answer a question by agreeing profoundly with you. I think that's actually a beautiful capsule summary of why behavior change is so difficult. Because even if you begin with the assumption that we all want to change our behavior, it's difficult. If you actually begin with a realistic assumption that people don't always want to be helped or helped in the way we would like to, it's even harder. And I guess I would partly answer by saying that I do think to an extent that's where biomedical advances will come to our rescue, because we have very powerful biomedical technologies either now or in the near future that will really make NCD management much, much easier and potentially open the way for reinforcing it with behavioral interventions. But your question is, yeah, spot on.
And David, I know that much of the work that we have shared and the wonderful analyst team, all the work that I share at the World Bank isn't done by me. It's done by these wonderful people. There's Joe, Santosh, David, the rest of the gang. I'm sorry for those I've missed are on the call. When we talk about impactability, trying to identify people who would be most benefit. But I think to your point, Joanne, there's a whole branch of this talking about more about amenability.
Yes.
It's about people who are amenable to change. There are very few people who don't want to change, but they don't want to change the way that we try to make them change. Yeah. So Andy, you need to lose weight, and I'm going to make you do exercise in this. That's not what I want to do. And I want to do something else. I'm going to give you an app for that. I don't want an app. And it's understanding what that person would be amenable to, because there's very, very few people who don't, when who when they're facing, a shortened life and a life with, or potentially a long life of pain and misery through long-term conditions and the mental issues that come with that as well. Or mental health issues come with that too. It's just getting the right intervention that they would most be amenable to.
Yeah.
I want Wegovy because I think the injections will make my life easy and I can lose weight that way. And yes, it may be more expensive, but that's better to me than exercise. And I know exercise may be better for my cardiovascular health too, but this is the one you're going to win on. And it's that amenability. Absolutely. And maybe we change that word from impactability. Sorry.
And that's so brilliant. And when if you do manage through drugs to stabilize your weight or your blood pressure or other conditions, it's a lot easier to begin exercise. The two are not opposed to each other.
Yeah, and it's really funny. And Ihan, I promise I do see your hand up. I will come to you. But what I found really interesting is that the big lifestyle change in Australia. So I remember visiting Australia, and I was very lucky to work in Canada for a bit. They were all so outdoorsy; it made you sick. You didn't go out for a drink or a thing. They went out to play tennis or hockey or whatever it was. You were always out doing something physical. That was built into the society. And Australia, yes, I felt, was very much like that. And this idea that you said that once society loses that, yes, you never regain it, I think will be a huge loss and a huge damage to Australia.
Yeah, I mean, Andy, my small example, I lived and worked in Australia for a while, and my abiding memory of Australia is these enormous parks that are empty the whole time. Every neighborhood has acres and acres of lovely green grass and everything. And I outside of formal sports, I could count on my hands when they're used these days. So empty parks is my synonym for modern Australia.
Nah, well, it's been what, over 15 years since I worked in Canada, in Victoria, Vancouver and on Victoria Island. So everyone was skiing and doing all that stuff. Yeah. But, you know, all the parks in the evening and they're all playing tennis all the time. So I'm sorry to yabble on, Ihan, over to you.
Well, it's been really interesting to hear your discussion. So yeah, I don't mind at all. It's just my question is actually related to what Joanna asked and our discussion about behavioral interventions. I agree with you that behavioral interventions are very difficult and there are a lot of challenges. And you mentioned one way of bypassing that challenge is maybe to adopt more digital technology, like the concept of permanent monitoring. I'm just wondering about the challenges of, like the behavioral challenges of adopting those digital technologies. Like we all know if everybody can have a wearable that gives them prompt feedback or can collect data automatically, that will give clinicians tons of useful data. However, people might not be incentivized to use those wearables, or even the Israelites women who receive the kit, they may not use it as often as they need. So I'm just wondering, any current discussions or like smart solutions on tackling that challenge?
Nice. Thank you very much, Jan. And back to amenability in different forms. It's such a nice example you've given. I would make a couple of points. I don't think that many countries have been really systematic about making remote devices available and ubiquitous. And I think where countries have done it, they have seen more uptake. So I do think better supply is a big part of the solution. I would begin with that. I also think we should be fairly shamelessly pragmatic about how we incentivize utilization. And cash incentives and in-kind incentives and material incentives work. So I don't think we should be at all embarrassed to use them if they're an effective way of offering people an opportunity. We have so many good developing country examples of using airtime as incentives for participation in health activities, for example. And that might not be the right one in the UK, but there are a host of incentives we can give. And our sense at the World Bank is incentives are usually cheaper than the alternatives. So yeah, I would just say let's be systematic about it and let's be very pragmatic about incentivizing through incentives if we need to.
Yeah, thank you very much, David. That's, I think, a very good starting point.
A very talented behavioural economist, and so all the stuff that I learned at school, David, where you would do whatever it was for a minute gain, she knows that it's all rubbish, and actually she better understands some people and everything from there. So thank you very much, Ihan, and I think it's one of the challenges we have when we're trying to look at interventions, certainly in ICSs or integrated care systems, yes, where some of the guys, including Ihan, has done some wonderful work looking at allocating resources appropriately. If you were to incentivize smoking cessation, why do the smokers get £5 where I, who don't smoke, don't get anything? And it's this idea that you have this friction between if local authority, if our friends in other kind of groups and third parties are incentivizing people to lose weight, to gain things. We've had people complain about putting boilers into houses that have terrible boilers and things. So these guys are having COPD exacerbations. We had the horrible, shocking news that in early this year, a young man died, because of his respiratory failure in England. Yes, this is 2023, because his housing situation was so poor that he died. And with all the care, he was being seen by the doctors, he was being seen by the but God forbid you put in double glazing and a boiler, because even though it's much, much cheaper, why does he get that and not me? And these are the frictions that are in place where, that incentivization, again, makes perfect sense to me, that is trying to get the rest of society to buy into, this is why they need it.
Yeah.
But anyway, sorry, thank you. I was keep ranting. Joanne.
Sorry, I wanted to continue the previous thread. Where I live, there are fourth generation non-workers.
Yes.
And their attitude to their own personal health and circumstances is very, very challenging. And that's going on to their children and onto their grandchildren. And the school that my nephews attended couldn't have sports teams because the parents thought it was a punishment that the children were selected to play in a team that stayed after school to train and then go to fixtures. So those are pretty entrenched ideologies from the people in these areas that are going to take some really hard unpicking to make any impact on.
And I think, Joanne, just before David comes in, this is where we start the real stress around getting societal buy-in rather than individual buy-in is so important. But David, you go.
And I just want to thank Joanne for such a wonderful example. And I do think if I were the UK, intergenerational deprivation would be one of the things that concerns me most. And I think that's been why one of the reasons why the UK has been slower to reduce poverty than potentially countries who've dealt with it better. And I would just re-emphasize that I don't think this is a health intervention. I think this is a societal intervention. Yeah.
Cool. Thank you ever so much. Joseph.
Hi, David. Just want to say thank you for your presentation earlier. It was really, really insightful. I guess kind of on a similar thread to the previous two questions. So I think we were talking more about like the societal buy-in, but I think I work as a data scientist for a mental health trust. One of the things that we face day in, day out is not necessarily societal buy-in, but more clinician buy-in. And this is maybe more back to basics, even with like simple analytical tools or statistics and things like that. And I know you mentioned a few studies earlier, as well as some actual interventions that have taken place. And I wondered if you've seen any good examples of ways that clinicians have had buy-in with using more advanced analytical techniques and data science tools and things like that.
I think the best examples we see are not so much clinicians as clinical care teams, because I don't think this is really going to be clinicians' sphere of strength necessarily. We've seen good examples, and they're good examples in Scandinavia, they're good examples in places like Costa Rica, of where you've got care teams with specialists who can help with digital integration. But I really do think it's a development of the theme we've made before in other regards of the importance of care teams with the right skills.
I think we were so lucky to spend some time in Sweden, and again, some of this is driven by necessity. It's that in the very north of Sweden, where people just can't get to the GP, they have these kind of wonderful digital hubs. Yeah. So these are healthcare hubs, and you can come and get a face-to-face video conference with a healthcare professional, but then they will take all of your readings, be able to help analyze this, give you the right, hopefully, prescription, whatever it may be, the intervention at the other side. And when I was over in Vancouver, again, the far north, because of the huge distances people have to travel, you've got to be really good with predictive algorithms, because by the time someone realizes they have an acute problem, if it takes them a day and a half to get to a hospital, And literally that's how long it would take some of these guys to get to hospital. It's it could be too late. So it's that idea of predictive analytics has such a, I think, an important role to play, and I think kind of the work you and your team do, Joe, can make such a difference. But it's getting, as you say, people to believe in it, I think, is and to be able to trust the maths. Because why would I will talk about professionalization of analysts quickly. Why would you trust us? We've, God forbid, we've only got degrees, masters, PhDs, decades of work and experience of using analytics to help you make decisions. Where I'm a clinician, surely I know best. And it's that, and it's the tension between those and how they can understand we're here to help, and how we can go from there.
Thank you.
Cheers.
I think all I would add is the more digital the overall system becomes, the more one has to rely on predictive analytics. So I think the process of digitalization itself creates momentum towards predictive analytics.
Yeah. No, thank you, Dave. And again, I know that some people on the call, when we think about data quality and data bias and all those things, of course, the more you use the data, the more that this washes out. And yes, there are some parts of the population that are less well represented, but again, there's ways to be able to try and drive them in, and they're the people you can encourage to participate. And we may not be insurance companies giving out free Apple Watches to reduce your insurance bill, but why wouldn't we do that anyway? Because we'll reduce the bill across the whole of the NHS for a whole myriad of things, and not that I want a free Apple Watch, but I'm not that I'm against one, but again, it's one of those things that can make a really big difference in gathering data and then being able to predict the future. Ashley, unless Joe, you've got anything, Joseph, if you've got anything else,
thank you.
Super. Ashley, over to you.
David, thanks so much for such a refreshing presentation. It's something, certainly some of those factors we're working on here at Loughborough University. As you can maybe guess, exercise is medicine is a big deal for us, but we're equally trying to stitch together everything around us in our daily lives. So we're looking at a multi-sector, multidisciplinary approach. I guess one of the things that we found in this fairly early stage is getting that buy-in from those that might want to fund, whether it is private or public sector. And some of these outcomes are quite long term. So I just wondered, from your perspective, what do you think the biggest leverage point here that we could maybe propose to governments or private sector? Is it, as we were saying earlier, is it a healthier nation that might be potentially more productive or less of a burden to the NHS, or maybe is it something else that might really get some significant investment in this space?
It's a great question. There's so many ways to answer it. I would always begin by saying one of my mentors at the World Bank, who was in management, and they always said, you're never going to get someone's business unless you figure out what keeps them awake at night and what they worry about in the shower. And unless you can relate it to people's real concerns, not what you perceive their concerns to be, you're not going to get very far. And an example I always give from my own work career is we worked a lot on promoting medically assisted therapy, substitution therapy for drug use in East Asia in an earlier career. And I remember part of a group that took a Vietnamese deputy prime minister to a methadone clinic in Hai Phong in Vietnam and showed him a picture of the car park before just as the program started, and then showed him the car park today, and it was full of Honda Dream scooters. And his vision was simply a vision where young people were gainfully employed, were earning a living, and weren't going to be part of a young nation that would rebel and overthrow him. So I think your advocacy arguments have to really be based on trying to understand what the hot button issues are for decision makers at the time, and not to have formulaic economic approaches, because, as you say, the rewards are long term, but decision makers' horizons are short term. So I think remorselessly focusing on what hot button issues you can use to press a point is, my only contribution.
Thanks, David. Cheers.
Thanks, Ashley. And how many Olympians has Loughborough produced? Anyway, that's
well, let's see if we can translate that to population. I guess that's
we just need, everyone just needs to have a Loughborough. That's it. But David, and for those in the audience, there's a wonderful paper by HEU who talks about why ICSs are bound to fail, or potentially bound to fail. because that integrated care systems don't have shared goals, they don't have shared visions, they don't have shared measures of success, no shared ways of moving money and other bits. So I know, just as David said, it's what's keeping all those people in the showers awake in an integrated care system are all very, very different. Obviously, mine is my rampaging toe fungus that needs to be fixed, but everybody else's is something much, much more important. And so once you align what's the problem, and so for us it may be deprivation and in inequalities, how is that framed for friends in local authority, in primary care, in justice, in treasury, in environment? How can you align your thing so you're getting the hot button, what's in the shower, aligned from there? Sorry, Andrew. We can't hear you, Andrew. Sorry.
Sorry, it's supposed to unmute by itself at the minute. It's not doing. Hope you can hear me now. David, thank you so much. Brilliant presentation. Andy, great points. And jealous of your time in Canada and Australia. It's been 10 years since I've been to Australia. Andy, on your point around, you're saying around the data and who are we with our PhDs and masters and, what do we know? Brilliant point. I've been with the CSU for about 12 months as the clinical lead. So my background is all very clinical and operational. And I think that my understanding of the power of data and analytics has come a long way in 12 months, and I can see the power and the rationale behind it. But I just wanted to make the point that I think the clinicians after data have to meet in the middle somewhere, because I remember with my training 20 years ago and training junior doctors and nurses, that data doesn't form any part of that training. And as the data becomes more personalised and powerful and detailed, we have to give the clinicians understanding, because ultimately it will be the clinicians applying that data to the patient. And I think that's really important. So I absolutely have an appreciation for your amazing work and what data does for us, but we have to be able to get the clinician to apply that, whether that's at the bedside or remote monitoring and you're receiving information. It's how we then apply that to the patient that's still really important.
No, thank you very much, Andrew. And just say that there was the wonderful Goldacre review that came out, I think, was it last year, or is it maybe it's 2 years ago? I'm getting old at these things. But a key part of that was to say, to get the best out of analytics, to get the best out of your analysts, be they data scientists, economists, where they need to sit cheek by jowl with the clinicians who have the problem. How can we help you do problem formulation? How can we make sure that the answer, very rarely is the dashboard an answer, even though we're asked to make lots of dashboards, or certainly when I first started in hospitals, every answer was a dashboard. And often pie charts just to wind you up, but actually it's sitting there to really understand if we have far too many people coming in readmissions. Why is there some variation? Let's really understand that variation so we can then help you do something different about that. But David, where have you seen success of people working together like this?
An example I like to give, I think, for my part, maybe the country that makes best use of predictive analytics is Israel, which, as you know, has 3 HMOs, universal healthcare through the 3, and they have 60 years of longitudinally linked biomedical data on everyone in the country. And I visited a program by a colleague, Rand Balasier, from one of the 3 big, the largest of the 3 HMOs, and he talked about a program that they introduced to basically use predictive analytics to identify all the negative outliers in their HMO catchment and to uplift them to the average standard. And he described how they did it, how the data was used, what interventions they put into place. And I turned to him and said, how did you, as the head of data science, convince people to do this? And he said, well, it helps, and I'm also the director of clinical services. So I do think part of the answer is trying to have the data science people in senior enough positions in one way or the other. Yeah, and that's definitely, to me, been one of the big success factors in Israel.
And I've seen exactly the same with Intermountain. Everyone told us Intermountain was the answer. They know how to do analytics and predictive analytics, but what they had was the same chairman, the same chief exec for 10 or 15 years who were completely bought into analytics,
Exactly.
made it happen. And so it's one of those things that, yes, it can work when systems, but as you say, Andrew, it's getting clinicians bought in, people understanding that on a sort of local level rather than
and I think what's important about this discussion is we're reframing it. I don't think using data analytics for better health outcomes is a technical challenge. It's a political challenge. We know we have the tools, we know they work, we know they make a difference. It's really moving this debate into the political sphere to give the momentum that we're talking about. And I think even that is quite important. We've come a long way if we agree on that.
I could feel me writing something for our health service journal on exactly that. That's great. Thank you ever so much, David. We have a minute left. So I just want to say a huge thank you. And thank you, Andrew. And for all of those who asked questions, you're ever so kind to spend your time with us. So we really do appreciate it. David, thank you ever so much for spending your time with us too. It's been really, really insightful.
Yeah.
And
on the contrary, I found it so enjoyable and rewarding and useful and informative. So thanks to everyone for great discussion.
You're very kind. And next time we're together talking World Bank, I promise I'll buy you a coffee. Not one of those crap ones that they give us that are outside for free. I will come out and buy you. And for all of those on the call, for any of you who want to talk about pop health management, the predictive analytics that David talked about, and beyond, please let us know. And we're very, very happy to talk about the work that we're doing with the World Bank and the work that we're doing across the country with other ICSs to be able to share that. And just to say, there's a great talk coming up with Stefan, who's one of our colleagues at the World Bank, who talks again about prevention, and we have some other people coming to talk too. But a huge thank you.
On that point, Andy, if I could just hijack. First of all, thank you, just to echo what Andy said. Thank you very much, David. Really interesting and informative presentation and great discussion afterwards. So thank you, everybody. I'm just going to share my screen very quickly. And as Andy was alluding to, we do have Stefan coming up, date to be confirmed. Our next guest in this series of discussions and presentations will be Esther Zenza. I hope I've pronounced that right. Thank you. And that will be on Tuesday, October the 3rd, originally scheduled for the 4th, but now on the 3rd at 11 AM till 12 noon. That will go live on the website soon. So if you want to get booked on that, I would urge you to do so as soon as the link becomes live.